Dr. Waxman, it's a pleasure as always, and great to see you.
Good to see you again, Lonnie, as well.
You know, we've had a chance to talk to a lot of the faculty, and it's nice to talk to you because you're one of the physicians that we really do, from the patients who support the foundation and the people that we talk to. They really value and appreciate your care, and I think they'll appreciate getting a chance to hear an interview like this just regarding your interest. Um, but one thing I don't think I've had ever a chance to even sit down and talk to you about and ask is, with everybody that's on the faculty, we have a lot of diverse backgrounds, a lot of diverse education backgrounds, a lot of impressive education that people have gone through to get to where you are in the department. Um, what started this for you? What was the path that really got you excited about medicine and in particular the kind of medicine that you practice? What were the points for you that really made you decide to make this your career?
Lonnie, I'm smiling because I got asked that same question when I interviewed for medical and graduate school back in 1984. I had to admit that my answer then sounded a little cliched, and I guess it still will. I was brought up to believe that it's our purpose on earth to help people. And I think it's the best reason to go into medicine, and it's also a great reason to pursue a career in science. As physicians, we get to have a direct impact on people's lives. We get to make this cool one-on-one connection. In ophthalmology, we work to preserve and restore what's arguably the most important sense we have, vision. Working in a field that allows me the chance to improve somebody's quality of life and maintain their independence, there's nothing like it. Of course, it doesn't hurt that our field has all the best gadgets and so much discovery to partake in. And in the academic health center, we also have the opportunity to have this enormous multiplier effect. We get to train medical students, we get to train residents, we get to train the fellows that will themselves go out and develop those same one-on-one connections and help people see. In our research endeavors, we get to work on projects that make entire groups of people see better. It's just been a wonderful career, and I'd advise anybody to think about heading this way as well.
Well, and thank you. And you brought up actually some of your research interest, and you have a pretty diverse, or I should say very, very, different focus in terms of research and your interest, very community focused interest in what you do, in addition to caring for patients. Could you talk to us a little bit about that, and what also started and maybe drove you to begin some of the work you do in the community?
I came out of the MD PhD program at Mount Sinai, absolutely sure I was going to be a traditional clinician scientist working at the bench. I had this neat project lined up where I was going to look at corneal wound healing, in particular the effects of the coagulation cascade on corneal wound healing. And it's one of the reasons I actually came here to Pitt, was because there was an active corneal wound healing research program. But the other thing that's always interested me through medical school and residency was the science of teaching. We kind of have an idea of the way students are supposed to learn in medicine, and it's probably wrong. The idea that you're going to pick up anything from sitting in a 1-hour talk, the idea that you're going to have assessments that drive improvement if you get an end of rotation evaluation, the idea that the way to learn something is to just repeat it over and over again. As it turns out, these are probably wrong. And we need to do the science necessary to figure out what works. Some of the things we know about already is that providing trainees, medical students, residents, fellows with more active feedback in a real-time way makes a difference. One of the things we've learned is that repetition, not in the sense of reading and rereading the same thing over again, but rather revisiting something days after you've learned it makes a difference as well. And one of the things we've started to understand is that you can actually learn a great deal about how to do surgery outside the operating room, so that when you bring a resident into the operating room for early surgical experiences, they have the skills and the confidence necessary so that they know they're going to do right by people. It's the science behind education is really very, very exciting. And I'm loving being a part of that. I think what you had in mind for me to discuss, though, was the other non-traditional, non-benchwork thing I'm working on. It turns out, there are these conditions in ophthalmology, glaucoma and diabetes, where they're overrepresented in underserved populations. These are conditions that don't have any symptoms until it's really late in the disease. And they're very treatable if you catch somebody early in the disease. Diabetic retinopathy, for instance, the government has recognized that every person with diabetes ought to have an exam once a year to make sure that they're not heading down the pathway of blindness, because we know that the leading cause of visual impairment and blindness in working age Americans is diabetes. Mm-hmm. And so there's this requirement that everyone who has diabetes gets an exam once a year. And even though we do a good job of advertising this, even though all our primary care colleagues know this, it's only about 50% of patients who have diabetes and get their eyes examined. And so recognizing this, we started fielding retina cameras into primary care offices. We figured that if we could get this retina exam done for diabetic retinopathy right where the patient was, while they were a captive audience with their primary care team or their endocrinologist, we could get them imaged. We could send the images off to somebody in ophthalmology, and we could tell the primary care team who was in trouble and needed to see us, and who, we could let off the hook and have them just get imaged again in a year. Mm-hmm. And this has been a wonderful success. We started out with one camera in one indigent care clinic. What was that, in 2006, Lonnie? And now we've got about
2010.
About 50 cameras mm-hmm. scattered all over Western Pennsylvania, as far north as Susquehanna, as far to the east as Harrisburg. And pre-pandemic, we were imaging about 700 patients a month. Wow. We were improving our quality scores. We were finding retinopathy that nobody knew about. We were getting people hooked up into the system. And now we're starting to see it ramp back up again. It's a lot of fun.
And the camera's like right behind you, right? I recognize it.
We've got, I've got 2 spare cameras in the office. You never know when one of the 50 cameras might go on the blink. It's good to have a spare around. And often I have an extra here. We like to give the primary care teams a taste. Mm-hmm. If we can give them a camera and loan it to them for a couple of months, they kind of get hooked on the idea. Yeah. That they're getting this done for their patients.
It really is a fantastic program.
It's been so much fun, and I think we've made a real dent in the screening rates in our area. But then, Lonnie, as you and I have discussed, we thought that we'd put these cameras out there and we'd get people screened and we'd find all this stuff that we needed to treat, and it'd be sunshine, unicorns, and rainbows. We'd have fixed the problem. And as it turns out, it's more complex than that. As it turns out, that even once you recognize that somebody needs to be seen by an ophthalmologist, after they've had a photo taken, after we recognize something on the photo that needs to be followed through on, it's not everybody that we send a report out on that ends up back in our care for follow-through. Mm-hmm. It's really, unless we take steps, it's about 1/3 of the patients who we recognize have a problem and recommend follow-through on that we can actually document follow-through. So now we're in this funny situation where we feel like we've succeeded in detecting disease, but we really haven't succeeded in preventing vision loss until we actually see those patients and give them the treatments they need. So,
what are the reasons why people who have been screened and they know that they need to have that follow-up, what are the reasons that they can't get there for the follow-up?
well, and that's exactly the best question. Traditionally, when people looked at barriers to screening for diabetic retinopathy and to care for diabetic retinopathy, they come with the traditional things you'd think about. And it's finances. Does somebody have insurance? Can they afford an exam? It's not just finances. There are a good number of people who might have coverage, but can't ever make it to the eye doc because they're working. And taking a day off from work for some people just isn't going to happen. Um, there are people who have enough other medical problems that the getting to the eye doc is one more thing that they just can't get to do. There's transportation issues. There's geography issues. We take care of people down in Greene County. We'll take our medical students and residents out there a couple of times a year, and there's just not an easy ophthalmologist. An ophthalmologist an easy distance of where their pickup truck will take them.
Right, right.
So there's all those traditional barriers that you'd think of right off the bat. And then when you start to talk to people, you realize it's not just those things. There's also a good amount of human nature and stubborn inertia to deal with. It's hard to value going to get an eye exam when, quite frankly, you're still seeing well.
Okay.
It's hard to be convinced that it's worth the time to travel to the eye doctor and check in and wait in the eye doctor's office for too long, and then go through getting dilating drops and all that, when you say to yourself, I'm seeing just fine. And so the education part of that and the human nature and inertia part of that is something we're coming to realize is important as well. And trying to find the right ways to overcome that is it's very exciting. It's really neat to try and figure out ways around our own biases as human beings.
Yeah, yeah. We're, I know that you've put a lot of thought and research behind it, and it is something that ultimately applies to, I'm sure, many areas in healthcare related to those types of follow through. But for vision care, it means that you lose vision, and nobody really would make a choice that would ultimately lead them to losing vision. So there is a lot of work to do, isn't there?
There really is, and I love that you brought up that it's an issue in other fields of medicine as well. I think all the time we see cases where a primary care doc, for instance, has made a referral out to a consultant or ordered a test, and a patient might fall through the cracks, not get to the consultant, not get the test followed through on. And, it's not surprising in some ways. Everybody who's ever had to deal with, going to a doctor's office or going to a hospital realizes just how difficult it is to navigate the healthcare system. If my wife calls up to make an appointment, she's an English literature PhD, finding her way through the phone trees and getting someone to agree that she needs an appointment, and it's tough.
Yeah.
Now imagine if you're not an English literature PhD.
Right, right.
And you're trying to figure out, again, is it really worth it that I do all this? How do I call the right person and say the right things so that I get the care I need at the right time? This is something we need to deal with across medicine. And so I'd encourage anybody who's interested in a career in medical research, but not necessarily interested in sitting at the bench and pipetting things, to start working with those of us who are interested in delivery of care and overcoming these social determinants and behavioral economics barriers to getting care. Forgive me for going on and on about this,
No,
but
it's okay.
failure to follow through, Lonnie, is an independent risk factor for disease. Everybody in medicine, we're always looking for ways we can change treatments so that people do better. But failure to follow through with the treatment, failure to take your medicine, failure to come back to the eye doctor when you're supposed to, this is an independent risk factor for poor outcomes.
Hmm.
And it's a modifiable risk factor.
Right. It
And
would be the
it's
most
something we
modifiable if we can get that around those barriers. Right.
absolutely, we think of this as a matter of personal responsibility. This person didn't follow through, and therefore, they, you know, hopefully we don't say things like they deserve what they get. Um, it's it's our job as physicians not just to prescribe the right stuff, but to do so in a way that helps to ensure that our patients get the care they need, follow through on the care they need, because that's what we really want. We want really good outcomes for our patients.
Hmm. Well, congratulations for all that you have done, but I know that you're not satisfied, and I know that you're driven to keep working on it, and we're certainly here to support that. The That's something that I know that you're proud of. But if I was to ask you, and you should be, but if I was to ask you what of the things you've been able to do, over the many years that you've been at this and doing, care and this research, as well as educating our residents, what would you feel would you feel is going to be, this is what Dr. Evan Jake Waxman is really the most proud of?
Oh, it's tough to say most, Lonnie. I'm really a lucky guy. Over my 20 years here at Pitt and UPMC, I've had the opportunity to wear a lot of hats
Hmm.
and participate in all parts of healthcare. Um, I think maybe the work I'm most proud of is the work I get to do as a teacher.
Hmm.
As you mentioned, I'm the residency program director for ophthalmology, and I'm the director of medical student education. Um, you got you used my line though, Lonnie. You said I was the principal for ophthalmology school. That's my line.
Sorry, I did steal that.
And so I love it when we have the medical students who not aren't necessarily going. I love it when we see a medical student and they get the ophthalmology bug
Hmm.
and they want to become part of the ophthalmology team. That's fantastic. But I also love it when we have the medical students who are going into primary care fields. They're going into internal medicine or family medicine. They're going to neurology. They're going into emergency medicine, and they get to see what it is the eye doctor does. They get to see how much patients value vision, and they get to learn enough about the eye so that they can make good referrals, so that they can call an eye doctor and present intelligently. And I'm easily as proud of the student who years later as an emergency medicine attending can get on the phone with me and tell me all about their eye patients' problems and make the appropriate referral, as I am in uh, the graduates of our medical school who go on to ophthalmology. Um, I love guiding our residents through their first eye exams. I love guiding our residents through their first eye surgeries. There's nothing like hearing from a graduate years later when they text back to tell me about a cool case or about one of their successes. It's a real kick when I see our graduates go on from our program to become leaders in ophthalmology education elsewhere. Um, so many of my graduates are teaching at academic health centers now, and a few of them are even residency program directors.
Oh yeah.
It's kind of cool. I have it's kind of like having kids and their trainees are grad students.
That's so cool. Yeah. Yeah. Yeah, I think I know that you're very proud of that, and that's why I brought it up. I think that the things we do to train our future practitioners and surgeons certainly it really is some of the most important work we do. So if I was to look at the future here, and what we're talking about here, and the Department of Ophthalmology. Of course, we have a lot of changes and a lot of growth going on. But as it relates to you and your passions and the things that we want to accomplish, that that I want to help you with as well, accomplish, what would your ideal vision of the future be in terms of what we can do together to make an impact?
It's so easy to get excited about all of the advances we have. I mean, so many things in ophthalmology have changed over the last, well, over my career. I don't think of it as that long a career, but okay, it's 20 years now. But there are complete changes in treatment paradigms. Macular degeneration was largely untreatable. The treatment for diabetic retinopathy is no longer to burn the retina. Um, and so the advances in treatment have been very exciting. The advances in technology have been so exciting. But what's neat is that we're at a turning point in ophthalmology and medicine in general, where we're starting to think hard, not just about what the next new treatment is, but how to get those treatments to the people who need them when they need them. And so we're thinking seriously and scientifically about social determinants of health and barriers to care and value in healthcare. We're starting to wrap our heads around personalizing treatments, but also personalizing our approach to delivering those treatments. And it's neat to see that there are more and more people interested in that side of medicine. I already mentioned that it's exciting to see the advances in medical education as well, and be a participant in that. Dr. Sahel was kind enough to get us the VR Magic IC surgical simulator, so we can have our residents train outside the operating room, building up the skills, building up the confidence they need, so that when we bring them into the operating room, it's like they already know how to operate. It feels like we're cheating, but you really get it. It's a science of education thing. It's also this profound ethical thing. Everybody has to do their first surgery in the operating room. Mm-hmm. Everybody who's going to go on to be an ophthalmologist or any kind of resident in any surgical field has to do their first case. But how many people really want their mom to be somebody's first case?
Right.
And so, wrestling with that tension is something that we did really poorly in medicine 25 years ago. Now, with all the surgical lab training we do, with all the simulator training we do, we really resolve this ethical tension by getting our residents the skills they need outside the operating room, so they can do the right thing when they're in the operating room. Mm-hmm. It's so neat to be part of that.
Well, this is what I can say regarding everything that we've just talked about today, is that you are always consistent and incredibly genuine and incredibly, caring about what you do. And it comes across in every time I've met you, and certainly did today. Thank you so much, because I really highly value the work you do, and I highly value, what we're trying to accomplish in the community, and the foundation certainly has helped you, but we want to continue to do so. And thanks for coming and spending some time doing this interview today.
Well, you're certainly welcome. And I thank you, Lonnie, for listening. And I want to thank, you and everybody else at the foundation and Dr. Sahel for, providing us with the startup tools we need when we want to get a project done. Getting that first camera out, that was a foundation thing.
Yeah.
Helping us get the funding from Pittsburgh Foundation for a coordinator for the camera project when it got big. Yeah. That was a foundation thing. Yeah. Getting us the dough we needed to put that, that IC simulator in the hands of our residents and fellows, that was a foundation thing. Yeah. You guys have just been so supportive of every crazy idea we've come up with. And I want to thank you.
Yeah, no, that's what we're here for, and that's exactly what we want to do, and certainly we want to tackle the challenges in the community as well, and more so than ever, we're realizing that we need to do more. So, thank you, and we'll look forward to more opportunities.
Okay.